Hello, today we start with two cases. The first case is primary pulmonary hypertension, pulmonary arterial hypertension, WHO group 1, a 32-year-old previously healthy female, presents with a 2-year history of progressively worsening dyspnea on exertion, fatigue, and 2 recent episodes of near syncope. On physical exam, her vital signs reveal a low normal blood pressure. A cardiac auscultation demonstrates a markedly increased pulmonary component to the second heart sound alongside a holosystolic tricuspid regurgitation murmur. Her electrocardiogram demonstrates right axis deviation and right ventricular hypertrophy, while transthoracic echocardiography reveals a dilated right ventricle, a D-shaped left ventricle due to systolic septal flattening, and an elevated estimated pulmonary artery systolic pressure calculated from the peak tricuspid regurgitant jet velocity. Extensive serological testing is negative for connective tissue disease, HIV, liver disease, and a ventilation perfusion scan is completely normal, ruling out secondary causes. A right heart catheterization confirms the diagnosis of primary idiopathic pulmonary arterial hypertension, demonstrating precapillary hemodynamics with a mean pulmonary artery pressure of 48 millimeters mercury, a normal pulmonary artery wedge pressure of 10 millimeter mercury, and an elevated pulmonary vascular resistance of 8 Woods units. The second case deals with post-pulmonary embolism, pulmonary hypertension, or chronic thromboembolic pulmonary hypertension CTEP, WHO group 4. The 58-year-old male presents with worsening exertional dyspnea and progressive lower extremity edema, noting a past medical history of an acute pulmonary embolism treated with standard anticoagulation 2 years ago. Physical examination is notable for an elevated jugular venous pulse, hepatomegaly, and peripheral edema, while his electrocardiogram shows signs of right ventricular strain, specifically the S1 Q3T3 pattern. Transthoracic echocardiography demonstrates a dilated hypokinetic right ventricle with decreased tricuspid annular plane systolic excursion, or TAPSE. The key diagnostic finding is on his ventilation perfusion scan, the preferred screening modality, which reveals multiple mismatched perfusion defects that strongly suggest chronic thromboembolic pulmonary hypertension, CTEP. Subsequent computed tomographic pulmonary angiography confirms the presence of organized fibrotic thrombi, webs, and bands in the proximal, lobar, and segmental pulmonary arteries. Following right heart catheterization that confirms precapillary pulmonary hypertension, mean PA pressure of 42 millimeters mercury, and a pulmonary artery wedge pressure of 12 millimeters mercury, is referred to an expert multidisciplinary center for evaluation for pulmonary endarterectomy, the gold standard and potentially curable surgical treatment for this condition. Slide 1, Introduction and Big Picture. Welcome everyone. In this session, I want to demystify pulmonary hypertension by moving beyond memorizing cutoffs. The key is to connect the numbers to physiology. Pulmonary hypertension is not just a pressure problem. It is a disease of the pulmonary circulation that eventually becomes a right ventricular problem. Today we will move from the hemodynamic definition to pathobiology, to classification, to diagnosis, and then to treatment. If you remember one global idea from this talk, let it be this. Patients with pulmonary hypertension do not usually die from pressure numbers alone. They do poorly when the right ventricle can no longer adapt. Updated hemodynamic definition. Start with the updated hemodynamic definition. Normal mean PA pressures is roughly 8 to 20 millimeters of mercury. Pulmonary hypertension is now defined as a mean pulmonary pressure of greater than 20 millimeters at rest. An elevated mean PA pressure is not enough to phenotype the patient. You still need to obtain the wedge pressure and the pulmonary capillary resistance calculation. That is how we distinguish pre-capillary disease from post-capillary disease, and that distinction completely changes management. This is the first big trap to avoid. Never diagnose a pulmonary vascular syndrome from one pressure number in isolation. Pathobiology and vascular remodeling. This explains why pulmonary hypertension is better understood as a panvasculopathy. The disease is driven by remodeling of the small pulmonary arteries. There is an imbalance between vasoconstrictions and especially endothelin and vasodilators such as nitric oxide and prostacyclin. Over time, you get medial hypertrophy, intimal fibrosis, and advanced disease, even plexiform lesions. The lumen narrows, resistance rises, and the right ventricle has to work harder. This is why group 1 pulmonary arterial hypertension is not just a spasm disorder, it is a structural vascular disease, and that is also why long-term therapy targets these three biological pathways. Why right ventricular failure matters. This is the clinical consequence that matters the most. Right ventricular failure. The survival determinant is in pulmonary hypertension is usually not the pulmonary artery pressure by itself, but whether the right ventricle can adapt to the afterload. Early on, the RV compensates with hypertrophy. Later, it dilates, stroke volume falls, and cardiac output drops. Once that transition happens, patients become much sicker. That is why symptoms such as worsening exertional intolerance, edema, syncope, and signs of congestion should never make you think about RV decompensation. In practice, when you assess a patient with pulmonary hypertension, always ask yourself not only how high the pressure is, but how the right ventricle is coping. WHO classification. The WHO clinical groups are essential because treatment depends on classification. Group 1 is pulmonary arterial hypertension or PAH, which includes idiopathic, heritable, and connective tissue associated disease. Group 2 is pulmonary hypertension due to left heart disease, and this is the most common category in real practice. Group 3 is due to lung disease or hypoxia, such as COPD or interstitial lung disease. Group 4 is chronic thromboembolic pulmonary hypertension or CTEP, and especially important because it may be surgically treatable. Group 5 includes multifactorial or unclear causes. Before anyone prescribes pH-specific drugs, the first job is to classify the patient correctly, pre-capillary versus post-capillary hemodynamics. Now apply hemodynamics to classification. In pre-capillary pulmonary hypertension, the bottleneck is in the pulmonary circulation. The wedge pressure is under 15 and the pulmonary vascular resistance is elevated. In isolated post-capillary pulmonary hypertension, the problem is left-sided filling pressures. So the wedge pressure is above 15 while the peripheral vascular resistance is not substantially elevated. Then there is a combined post and pre-capillary disease where chronic left-sided disease has triggered secondary pulmonary vascular remodeling. This is a high-yield examination concept because the same patient may have elevated pulmonary pressures for very different reasons, and the wrong treatment can be harmful. Diagnostic pathway. The diagnostic pathway begins with suspicion, not with catheterization. Echocardiography is the screening test because it estimates the probability of pulmonary hypertension, often using tricuspid regurgitation velocity and supportive RV findings. But echo does not make the final diagnosis. A VQ scan is mandatory when you're evaluating for chronic thromboembolic disease because CT angiography alone can miss it. And the gold standard remains right heart catheterization. The sequence is simple. Echo raises suspicion, VQ scan helps exclude group 4 disease, and right heart catheterization confirms the diagnosis and phenotype. Right heart catheterization. Right heart catheterization is the decisive test. You need accurate measurement of mean pulmonary artery pressure, pulmonary artery wedge pressure measured at end expiration, and cardiac output. These values allow you to calculate pulmonary vascular resistance and classify the syndrome correctly. In selected patients with suspected group 1 pulmonary arterial hypertension, vasoreactivity testing identifies a race subgroup that may respond to high-dose calcium channel blockers. Another important point to remember is that catheterization is safe when performed in experienced centers. So the message is this: do not be satisfied with an echo-based label of pulmonary hypertension when management decisions depend on invasive hemodynamics. Risk assessment and follow-up. Risk assessment in pulmonary hypertension is really an attempt to predict survival and to estimate how close the right ventricle is to failing. Clinical status still matters a great deal, especially WHO functional class. Exercise capacity also matters, often measured by the 6-minute walk test. Then come the biomarkers and hemodynamics, including BNP or NT-proBNP, right atrial pressure, and cardiac output. When these worsen, the patient is telling you that RV strain is increasing. The practical lesson is that pulmonary hypertension management is longitudinal. You do not re-stratify once. You reassess repeatedly and escalate therapy when the patients move into a higher risk profile. Targeted therapy for group 1 pulmonary arterial hypertension. Now, targeted therapy for group 1 pulmonary hypertension includes 3 classic treatment pathways. First, the endothelin pathway. The endothelin receptor antagonists block one of the most important vasoconstrictive and proliferative signals in PAH. Common examples are bosentan, embisartan, and macitentan. Second, the nitric oxide pathway. PDE5 inhibitors such as sildenafil and tadalafil enhance nitric oxide mediated signaling and improve vasodilation. Third, the prostacyclin pathway. Prostacyclin analogs and receptor agonists provide potent vasodilation and antiproliferation effects, especially in more advanced disease. Something to remember is to recall that these drugs are primarily for group 1 PAH, not for every patient with elevated pulmonary pressure. Group 2 and group 3 disease. For groups 2 and group 3, the central principle is to treat the underlying cause rather than the reflexively reaching for PAH drugs. In group 2 pulmonary hypertension, optimize left-sided heart failure, blood pressure, valve disease, and volume status. In group 3 disease, treat hypoxemia and the lung disorder itself. Systemic vasodilators can worsen ventilation perfusion matching. There is an important nuance from the source material which includes a Go Deep meta-registry of 836 patients and COPD and pulmonary hypertension that found poor 5-year transplant-free survival and higher predicted PVR outcome. In that registry, PDE5 inhibitor was associated with lower mortality, but this was observational data, so it should be viewed as hypothesis generating rather than automatic routine practice. CTEP, the potentially treatable group. Group 4 disease is special because it may be curable. Chronic thromboembolic pulmonary hypertension begins with unresolved thromboembolic obstruction, but over time it also creates a secondary microvascular arteriopathy. That is why the disease can persist even after the original clot burden seems remote. The treatment of choice for operable disease is pulmonary endarterectomy, which can be transformative. For patients who are inoperable or who have residual disease after surgery, balloon pulmonary angioplasty and Rycoguat are important options. So whenever you suspect pulmonary hypertension, do not forget the VQ scan. Missing CTAP means missing one of the few potentially curable forms. Perioperative and cardiac surgery considerations. This cardiac surgery slide is especially relevant for people rotating through ICU or OR. Pulmonary hypertension raises perioperative risk because the right ventricle may not tolerate changes in preload, afterload, hypoxia, hypercapnia, or acidosis. One concept is protonin reaction. For heparin reversible, sometimes patients are given protonin, and that can cause acute pulmonary vasoconstriction with abrupt RV failure. When severe pulmonary hypertension is present, selective pulmonary vasodilators such as inhaled nitric oxide or inhaled prostacyclins may help because they reduce pulmonary vascular tone without causing the same degree of systemic hypotension. In these patients, anticipation and hemodynamic planning are everything. Closing message, referral and correct phenotyping. I close with a systems-based message. Pulmonary hypertension is often diagnosed late because the early symptoms are nonspecific: dyspnea, fatigue, edema, reduced exercise tolerance. Referral to expert centers matters because classification, catheterization technique, vasoreactivity testing, surgical evaluation, and longitudinal risk assessment are all nuanced. The golden rule is accurate WHO classification comes first. Treating a group 2 or group 3 patient as if they have group 1 PAH can do harm. The safest and most effective approach is disciplined phenotyping, thoughtful referral, and constant attention to right ventricular physiology. Thank you for watching.